Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM. This is a presentation on cardiology topics. The focus of presentation is a continuation of my EKG interpretation book. This time it is chapter 6, which is going to be on sinus node dysfunction. So let us begin with the feature presentation, sinus node dysfunction. We're going to be talking about sinus pauses, sinus exit block, cyanoatrial block, sinus arrhythmia, sick sinus syndrome, and hyperdynamic circulation. Hyperdynamic circulation is where there is excessive sympathetic drive of unexplained reason, where the heart responds with the increased heart rate in response to any kind of physical or emotional distress. So let us begin with the sinus pauses. What does sinus pause mean? Before we go into understanding what is sinus pause, we need to look at the electrical system. As you can see, we have the sinus node here, which is like a specialized myoepithelial cell. Then we have the interatrial connections that go to the AV node. The impulse has to come from the sinus node. Think of it as a box, and from there it has to exit the sinus node to activate the atrial muscle. So the time taken by the impulse from the sinus node where it originates to reach the atrium is an important feature which is not normally seen on the electrocardiograms. Unless you do a cyanoelectrogram using special catheters, you will not know when the sinus node fires and when the impulse reaches the atrium. So in cases of sinus pauses, the sinus node may be firing at a set rate of 60 or 70, but however, the impulse may be totally blocked, like in patients with complete heart block, where the atrial impulse cannot get to the ventricles. Then the ventricles have to beat on their own. Whereas here, because there is block to the sinus excitation exit, there is loss of atrial activation, which is reflected here. We have a sinus beat represented by the atrial activation with P waves, P waves. We don't have any P waves, no P waves, no P waves, and now the next P wave comes. The interesting thing is the interval is multiples of the PP interval. So there's no change in the rate because the sinus is firing at the same rate of 60 or 70, but it cannot get out of the sinus node itself. As a result, the atria are just sitting quietly. As I said, I am not getting any excitation, so I'm going to wait for the next excitable event from the sinus node. And when it does arrive, you see a normal beat. So if you see anything like this, you should be considering sinus pauses, especially if the interval between this P to this P is a multiple of the PP interval. If it is variable, then we may be dealing with a sinus arrhythmia. So we have to differentiate that with the sinus arrhythmia. We also need to differentiate this with a sort of a high-grade AV block. Whereas with high-grade AV block, you do see P waves, you just don't see the conduction through the AV node to give the QRS complexes. So if you see a pause with just P waves in between, you're dealing with a high-grade AV block. If you don't see P waves at all, then you're looking at the sinus pause or sinus exit block. Okay, let's move on. Sinus exit block, couple of points. Here the sinus node depolarizes, but the impulse is not able to reach the atrium, which I explained to you. There are two kinds of sinus node blocks, which is the first degree sinus block, where the sinus node impulse slows down on the electrocardiogram, but the electrocardiogram may look normal. We also have a second degree type Wenckebach style cyanoatrial block. And let me see if I can explain this to you. You have to actually put a tracing of the Wenckebach at the AV nodal level, and then it will make things a lot easier. In other words, I'm using the same principle as we use in like AV nodal Wenckebach. That is, you have the atrial impulse coming here, and the AB node is kind of deceased, so that there is prolongation of the PR interval with successive beats leading to shortening of the RR intervals. That is in the AB nodal Venke block, whereas with sinus exit block we see a similar picture, except you have an imaginary sinus activation here recorded by an electrode, and we have the sinus node, and they are going at a constant rate, just like the PP intervals. But by the time it activates the atria, there is progressive prolongation of the cyanoatrial interval. As a result, the PP intervals get shorter, just like the QRS impulse intervals get shorter in the regular Venke block. So if you see something where the PP intervals are getting shorter until you see a dropped P wave, then you should be thinking about cyanoatrial Venke block. You may never see this, but it's important to know, especially if you're a cardiology fellow. You may see an example of this on your EKG section of the cardiology boards, because this is a very tricky one. This is something you really don't pay attention to. This is something that does not make a big clinical difference unless you're dealing with a sick sinus syndrome, in which case you treat them with a pacemaker. Okay, let's move on to the cyanoatrial exit block type 2. What do we see in like AB nodal Venke block Mobitz type 2? We have dropped QRS complexes. We see P waves, maybe two P waves and no QRS complexes. So that is exactly what we are seeing here, but here the P intervals are constant, and if you put a sinus electrogram, your sinus and P intervals are going to be constant, but there's going to be a dropped beat, and there's going to be multiples of the basic PP cycle. Again, these are extremely rare conditions, but as a cardiology fellow, you are expected to know these things, because these could be 2-3 questions on your EKG section of cardiology boards. Let's move on to sinus arrhythmia. Sinus arrhythmia is where you see a P preceding each QRS complex. The RR intervals can be varying quite significantly, because that is the hallmark of a sinus arrhythmia. Sometimes we see respiratory variations, but they are cyclical. That means you see them in a certain pattern, whereas with sinus arrhythmia, it's just like atrial fibrillation. It has no rhyme or reason. It just varies from beat to beat, and it may change also with respirations, but independently of the respirations, it can have variations. Sinus arrhythmia is supposed to be an increased vagal tone, but clinically it should not make much difference unless you are seeing ectopic atrial beats along with that, which may suggest the development of atrial fibrillation in an unstable cardiac patient, which I have seen. Then we have the sixth sinus syndrome, the tachy-Brady syndrome. You may have runs of atrial fibrillation, then you may have runs of a sinus rhythm, then you may have pauses. This is classical of a tracing that we would see in patients with sixth sinus syndrome, especially in the presence of atrial fibrillation, which is intermittent. We have runs of atrial fibrillation followed by pause, then maybe an attempt to re-establish the sinus rhythm for a few beats, then it goes back and forth. Of course, the treatment for sixth sinus syndrome is going to be a pacemaker insertion. This is something can be easily picked up on a 24, 48 hours or a 14-day monitoring, and especially if this is associated with the symptoms like weakness or dizziness, it certainly needs attention, and the treatment of choice is going to be pacemaker. To control the slower heart rate here, then we can use drugs without hesitation in controlling the rapid heartbeats in patients with sixth sinus syndrome. So ladies and gentlemen, this is a very quick crash course on chest pulse variations. Of course, this is a sinus node dysfunction. Thank you so much for watching this presentation. We have more than 50 videos covering the ABIM Cardiology Medical Knowledge Self-Assessment Review, Please do watch them, and hopefully it will help you a great deal in passing the cardiology section of your medicine boards or even cardiology boards, because there's a lot of fundamental information. And please do subscribe to our YouTube channel, and I will see you in the next video. Thank you so much.